Hello, everyone, and welcome to Database and Methods, a cyber seminar series hosted by VIReC, the VA Information Resource Center. Thank you to CIDR for providing technical and promotional support. Database and Methods is one of VIReC's core cyber seminar series, and it focuses on helping VA researchers access and use VA databases. This slide shows the series schedule for the year. Sessions are typically held on the first Monday of every month at 1 p.m. Eastern. More information about this series and other VIReC cyber seminars is available on VIReC's website, and you can view past sessions on HSR&D's VIReC Cyber Seminar Archive. A quick reminder to those of you just signing on, slides are available to download. This is a screenshot of a sample email you should have received today before the session. In it, you will find the link to download the slides. Today's presentation is titled Identifying Non-Traditional Encounters for Research and QI and Real-Time Identification of Study Participants, Application to Whole Health Services. It will be presented by Rian Defaccio, Amy Douglas, and Xiaoyi Zhang. Rian is a statistical analyst at the Seattle Center of Innovation for Veteran-Centered and Value-Driven Care. His work focuses on the analysis and validation of electronic medical record data to support multiple operational centers and research teams. His skills in statistical programming, data management, clinical trials, and observational epidemiology support projects across many domains, including whole health and CIH implementation, COVID-19 treatments and outcomes, and HIV disease management. Jamie is also a statistical analyst at the Seattle Center of Innovation for Veteran-Centered and Value-Driven Care. Jamie's work includes the creation and analysis of research data sets from medical record data, survey responses, and trial data. Her current areas of focus include whole health and CIH implementation, opiate reduction, chronic disease management, and behavioral intervention. Xiaoyi is a second-year PhD student in biomedical and health informatics at the University of Washington. Her research interests are data mining and machine learning and their applications in healthcare. She is currently a VA research assistant working on whole health and CIH survey sampling. Thank you all for joining us today. And I will pass this on to Rian. Just a moment, Rian. Okay, here you go.
Awesome. Thank you, Erica. Okay. So our goals today is we've been working with this process of sort of identifying non-traditional or types of visits that probably didn't even exist a few years ago for a couple of years now. So we're going to kind of walk through how to develop a process to identify these new and emerging visit types. And it is true, they are constantly changing. We're going to walk through an example, sort of in depth, of how to identify these non-traditional visits. We're going to apply these lessons sort of in a broad sense to a more specific example to build a real-time cohort for survey administration, something where you want to find patients sort of week to week. And then we'll sort of assess these opportunities to coordinate with like the sites where this stuff is actually happening, where the coding is happening, to see, to get a better picture, to sort of validate our processes and make sure we're actually coding the things that we think we're coding. So first thing, let's just get a feeling for who's in attendance today. We'll do a quick poll question asking, what is your role in research and or quality improvement projects? Are you an investigator, PI, or co-investigator? Are you a statistician, data manager, analyst, or programmer? Are you a project coordinator? Or if you're something else, if you feel like it, describe your role in the chat.
Great, and thank you, Ryan. That poll is now open and our results are slowly coming in. We'll just let that run for about 10 more seconds before I close out the poll. And please remember to hit submit once you select your poll choice, or else it's not going to get recorded. All right, things seem to have slowed down, so I'm gonna go ahead and just close out that poll. Okay, and let me see. And a second, and I'm gonna share the results with everyone. We have 10% that said investigator, PI, COI, 22% said statistician, data manager, 17% said project coordinator, and then 2% said other, and I can see that one of those are PhD, RN, nurse scientists. And back to you, Ryan.
Okay, thank you. So moving along, one more poll question. How many years of experience working with VA data? Do you have none, a year or less, between 1 and 3 years, at least 3 up to 7, or at least 7 up to 10 years, or 10 years or more experience working with VA data?
Great. So that poll is open and running. We'll just give that. Sorry, I thought I'd open it, but apparently I didn't. So it's now open. Please select your answer and please hit submit. I'll just let that, our answers are coming in quite slowly. I'll just let that run for a few more seconds before closing the poll out. All right, seems things have slowed down quite a bit. So I'm going to just go ahead and close that poll and share the results. We have, let's see. We have 3% said A, none, I'm brand new to this. 8% said B, 1 year or less. 19% said C, more than 1, less than 3 years. 19% said at least 3, less than 7 years. And then 0% said E, at least 7, less than 10. And 5% said 10 years or more. Back to you, Ryan.
Okay, thank you, Whitney. So again, our broad picture today, we're going to talk a little bit of background, just about whole health, complementary and integrative health, non-traditional encounters. We're going to go through a specific example. We're going to talk about some cleaning and data wrangling. We'll talk about working with subject matter experts and identifying new users for a rapid evaluation, in this case, a survey. So we'll start here with a little background. So whole health in the Veterans Health Association. This is a quick and dirty history. So in 2013, the Office of Patient-Centered Care and Cultural Transformation, we call it OPCCCT, began developing a new model of care around whole health, which, quote, approaches healthcare in a way that empowers and equips people to take charge of their health and well-being and live their life to the fullest. So this model had 3 main portions. There was a pathway, which included a lot of classes, group classes, some individual coaching to introduce veterans to this idea. There was this notion of whole health clinical care, which is where healthcare providers, primary care providers mostly, provide care in a way that focuses on the goals of the veteran. And also these well-being programs. So the CIH is included here, all these complementary forms of care. We have some additional coaching, we have some self-care, we have nutrition and movement skills. So a lot of these things are things that we try to track. By 2016, with the passing of the CARA Act, there was a large expansion. And in the coming years, the general goal is to expand this model to all primary care and mental health. So an integrating of this model into all aspects of veterans care. So here we can just see, you know, this is very much a national program. You can kind of see where it started, our little squares, and then all the various phases where this has been rolling out to eventually encompass, you know, most all components of the care that veterans will receive. So if you are interested in learning more about the system, there's a lot of information on the Whole Health Guide. You can look at the official implementation guide. It has, you know, training opportunities, suggestions on setting up your core offerings. Also constantly changing, so I would just refer you to the whole health site here. So some types of non-traditional encounters, many of which we attempt to track in the Office of Patient-Centered Care, is whole health clinical care, the pathway, the coaching, and the skill building classes, chiropractic care, which is sometimes considered separate from CIH, and then all these complementary and integrative health therapies such as yoga and massage. Also important to sort of set the stage was the CARE Act. So this was part of Congress's response to the opioid crisis, and VA received a lot of funding to address this, and whole health was a large part of that picture. We wanted to find ways to treat chronic pain, especially reduce opioid prescriptions. So to do this, to understand if we were actually solving this problem, the very, very large first step was to just sort of determine, are these things actually happening? So then we had to, start learning how to track and do assessments. So one place where this is still happening is the OPCCCT evaluation dashboard. So you can go here and look, and you can look for your specific site. You can look by different years. You can break it down and look at how much yoga or how much Tai Chi are patients in your center receiving. So this is one method for evaluating use. Another method, and this is where our office here in Seattle and some other places work, is to do evaluations of utilization in these annual reports we call the CIH Compendium. So here we took a bit of a more detailed look at use in the VA. And specifically, we're identifying all this use exclusively through the CDW, so through various coding practices. And these reports have been coming out yearly, so you can look here to look at these. This is from fiscal years 2017 through 2019. So with that crash course in the history of whole health and CIH in the VA, let's do another poll question, which is just assessing what is your interest in today's presentation on non-traditional encounters. Are you mostly interested in whole health or CIH encounters? Are you here to learn about how to apply methods to other non-traditional encounters for your own studies? Are you just generally interested? Nothing in specific? Or if something other, please describe it in the chat.
Thank you, Ryan. So the poll is open. It should have appeared on the right-hand side of your screen, your WebEx interface, and just please remember to hit submit once you've selected your answer choices. You don't hit submit, the answer is not going to get recorded. So our answers are coming in and quite slowly, but it seems like things have tapered off. So I'm just going to go ahead and close that poll and share the results. So we have 15% said A, mostly interested in whole health CIH encounters, and 18% said B, here to learn how to apply methods to other non-traditional encounters, and 11% said C, general interest, and 2% said others. And the only thing I'm seeing is the psychosocial rehabilitation program was provided to veterans for 3 years based on the therapeutic strategy to address victims of apartheid in Swaziland, South Africa, and it worked. So that was the only comment I saw for other. And back to you, Ryan.
Okay, thank you. So back to our roadmap. We're going to go into the weeds a little bit here now. We're going to look at a specific example of using the CDW and a lot of available coding concepts to work through one example here. So we are going to use therapeutic massage as an example. So when we considered how to define a massage visit, there were a number of sources that we went to. So one, in this case, there were CPT codes. We'll see there's other examples where you may not have any CPT codes at all. the char4 codes. So the sort of addition to your basic stop codes, the extension, we can look at those. We'll look at location names, where are the visits occurring. We'll look at note titles, so the titles from the TIU notes, and we'll look at HealthFactors. So first things first, just as a general rule, we would go through and exclude your test patients, and in this case, we wanted to restrict to veterans. And then we found a number of visits. We are only going to consider VA care for this example. So we did pull community care because we very much cared about that, but we pulled them from the PIT tables, but we excluded those here. So here we can see some examples where we exclude. If the stop code was one of these, we can see non-VA, chiropractic care outside VA. So we're only considering for this example VA visits. The community care visits were a separate process. So first, we looked at CPT codes. In this case, we identified CPT codes that would apply to massage through our operational partner. So this is OPCCCT, and there was a single CPT in this case. But we'll see there were other therapies that had more or fewer. Meditation didn't have any CPT codes. Acupuncture had 4 CPT codes, so it just depends. And this is where you would talk with, I don't know, subject matter experts or your operational partner to sort of at least have somewhere to start. The next option that we looked at was the char4 codes. So these are modifiers to stop codes, just giving more detail on a location of service. And when we were looking this up, even over time, our process has changed for finding this. There's these national codes, which you can extract from any outpatient visit. So we're in the weeds here, so we're going to be talking about some CDW tables. So you can get these via the DSS location dimension tables. And so you can get a char4 for a specific visit. We had previously actually used data from the MCAO extracts, data extracts. And so this is financial billing data. These cannot actually be explicitly linked to a particular visit, but you can sort of match on the patient, the day, the location, and you can get it to be very close, and in most cases exact. For a number of reasons, we ended up switching to using national codes at one point. So for massage, there was a single char4 code, this MSGT. Also, sort of some context for the entire process here. These new char4s were created sort of in conjunction, in this case, between this office, OPCCT, and the MCAO. So these new char4s were created during this sort of whole health expansion. There was the VIReC, the Office of sort of Financial Incentives, offered money to sites if they coded certain whole health things. So there's sort of an incentive for sites to code whole health. However, VIReC was only incentivizing ICD and CPT codes. So these char4s and HealthFactors, just sort of recognizing there's an incentive for sites to code certain things and maybe not other things. So we just being aware of what is the process going into the coding of some visits you might be interested in. So these were the char4s. We also looked at location names. So for this, as a general pattern, we first look for a positive match, in this case, anything with massage in the name of the location. But then we'd have to do, these are just some examples, we would have 20 or 30 exclusions for each. So something where it said research or so choice and community care, we wanted to exclude those. We're going to get those in a different way. We were finding a lot of acupuncture in these massage-like names, so we excluded those because acupuncture was a separate thing. So just this general pattern of finding a positive match and then excluding things that aren't quite right. So we did these for each visit. For the note titles, so the TIU notes are unstructured text, but we just used the note titles from this TIU document table. And again, these are linked directly to the outpatient visits. Same general idea here, find a positive match and then a number of exclusions. We'll always see this research exclusion or acupressure. A lot of times the exclusions were when we had similar types of visits. So maybe acupressure and massage, and we really wanted to distinguish those two. So you'll see in the acupressure, we probably excluded definitions that had massage, vice versa. So our next group of coding concepts was HealthFactors. These are templates, which are supposed to be standardized, but often we find they are not. So we actually have to look, again, using this sort of fuzzy string matching. We first look for a health factor that looks like massage, and then we exclude. And these are also linked directly to those outpatient visits. And so also just as a general concept, all these things we're looking at is sort of in the outpatient domain. There's probably a whole nother host of considerations, different tables if you were doing inpatient coding. And then a last thing that we had to consider in the last year, especially, was identifying telehealth. So to do this, we made a list of stop codes and location names, and we collected any visit that had one of these stop codes or any of these. These are just a few of these location names. And if we found these, then we would identify a visit as being a televisit. So this was sort of a tack on. We first collected all our visits and then said, is that visit a televisit? So those are just a collection of all the concepts that you could use to define a non-traditional visit. So then we sort of had to clean up all this data and avoid double counting, do some deduplicating. So we wanted to get to a patient day table. So this was sort of an aggregating process. So for any patient, and this is sort of a decision that has to be made on a case-by-case basis for any given study, we decided we wanted to have one patient per visit type on a given day. So duplicates are removed. So a patient could have a single yoga visit on a given day. If we found 2 yoga visits, we just sort of reduced that down to where there was 1 visit. But then a patient could have a yoga and a massage and a core whole health all on the same day. That was allowed. And then another decision we made was any indication of an in-person visit took precedence over indications of a televisit. So you only counted a patient day as a televisit if all that we could find for that day were televisits. And so this is just some example SQL kind of showing the logic of how we determined in-person versus televisits. And so then what we had to do was, in some cases, so if a visit on a given day was only identified via, for instance, a note title, a TIU note title, then we went through and did some additional exclusions. So if we only found a visit through a note title, we then would also remove notes where we had, sorry, let me go back a little bit. So for this example here, these are visits where we only determined it was, let's say, massage via a location name. Then we would go look at the note titles for that visit. And if they fit into any one of these things here, so cancel, was the visit canceled, dental, like things that don't really line up, then we would actually remove that visit. We'd say this visit doesn't count. So these additional exclusions were in the cases where a visit was only identified by a note title or only identified by a location name. So many of the visits would be identified by CPTs and char4s and note titles, maybe and a location. So there'd be, a visit could be identified by any one of these 5 different methods or several of them. And then what we got at the end through this whole deduplicating process was a whole bunch of visits that were identified in different ways. So for instance, massage, we found a lot of the visits were identified by CPT only, but some of the visits were identified by, you can see the overlap of almost 3,000 here. So visits identified by all the methods. The outer rings here are like location notes only or location titles only, char4s only. And compare that to, say, maybe chiropractic care. So this is something that's been traditionally tracked for a lot longer. We see a lot more overlap. Then compared to something like biofeedback, where there's very little overlap and it's mostly all by HealthFactors and char4. And so this is sort of to be expected as these new things are being coded. And actually, even in massage, you can see there's some that were only identified by HealthFactors. So we get this sort of aggregate picture of how are we identifying all these different methods. And so that's a broad overview of how we identified massage in this case, using all these different coding concepts, and then sort of used some logic. We had to make some decisions in the end about what constitutes a visit, what constitutes a televisit. And it's never perfect, but we're always sort of iterating and going back and looking at things. So I'm going to hand it off now to Jamie to talk a little bit about this next topic. So Jamie, I'm going to hand it off to you.
Thanks, Ryan. So this whole process starts with the Office of Patient-Centered Care Guidance. They have published this whole manual on how these encounters should be coded. And then we've put together code that we believe should accurately capture visits. But then we have this code and we have these visits, and how do we know that we're actually getting them in the same way that the sites are doing them, in the same way that the patients are receiving them? So one way that we validate our data is through subject matter expert guidance. Some of our subject matter experts are providers who are coding on the ground, others who are experts in this area. They can help us to disentangle the procedures and documentation. Often there will be some sort of fuzzy areas where a procedure will count as chiro if it goes with another procedure, but not if it doesn't. And so a lot of those are difficult for us to personally disentangle, and we'll need just a little bit of coaching. We dialogue with the sites where whole health and CIH are implemented to see how they're actually coding things and to see if the encounters that we're seeing match up with the encounters that they believe they're providing. And then we also have patient surveys out where we ask patients what sort of services they're receiving and participating in. And we can attempt to validate the data that we are seeing in the medical record that way. This process is iterative. We'll often, the sites will tell us, we'll bring up a concern, we'll do a recode, and then we'll find a new thing that we have questions about. And so we'll have to go back, and then sometimes we bounce it back up to the subject matter experts. And it's fluid. This is definitely an evolving process. The sites are constantly updating the way that they code because many of these encounters are new. And so this is definitely an evolving process. So one of the ways that we validate this data is through our site partners. There are 18 flagship sites across the country that have been running large-scale demonstrations of whole health since 2016. Those are our site experts. We meet with them quarterly to share patient and encounter data with them. We talk to providers and people who are managing their whole health programs. We present them with a lot of our data to try to figure out if we're getting the right volumes, if their clinics are correctly assigned to the modalities. And then when we have questions about coding that is ambiguous, some things that might be ambiguous or things that we have a clinic name, but we don't have a CPT code, things that say consult, times when a different clinic name, the clinic name and CPT code suggests a different type of therapy, like massage happening in a chiro clinic. And we get to hear their thoughts on what is going on and how we can improve our data. And so I've just pulled a little graphic from something that we show them to sort of show them where their visits are happening. And so we'll show them on the bottom here their modalities. We have acupuncture, we have chiro, we have massage, meditation, tai chi, and yoga. And this is for the St. Louis clinic. And then we show them for their clinics in CBOX where we think those encounters are happening. So sometimes we'll hear, we don't actually have a meditation clinic running at Washington. Where are you guys getting that? And so then we can go back and check and see what needs to be excluded or recoded so that we aren't getting visits that don't exist. So to take massage for an example, the sites have revealed a variety of nuances that we would certainly not have discovered from looking at the EHR alone. From one site, they said that the massage char4 is actually used for cupping therapy. Cupping therapy is acupuncture. We don't include it in massage. We often hear that massage is offered by PM&R, by physical therapists, and that it's not part of the whole health program or complementary health therapies. That's useful for us to understand sort of the context of the site. And then we sometimes hear that if there was no CPT, the patient might have been evaluated as not an appropriate candidate for that therapy when the clinic visit began. We have, in many of our projects, as a result of site visit data, we've decided not to count consult notes and a couple of other things because we don't think that the patient actually received that therapy. So some lessons that we've learned from the site level validation is that overall we're doing a really good job. The data that we get in the EHR really does allow us to confidently identify these visits, and we think we're doing that with fair accuracy. The way the visitor coding is evolving, especially because of how relatively new this is, there's a good chance that nobody will know how, what you were looking at 3 years ago in the data. So pulling retrospective data can be very complicated because the sites are evolving their coding and improving it. And so if you're seeing something that looks a little strange, solid chance that it's just not being done anymore. Whoever was doing it may have moved on. And so pulling retrospective data with these non-traditional encounters can be a bit of a challenge. And then we have different levels of accuracy for different purposes. We have projects where we just want to get the overall picture, anything that even smells like massage, we're grabbing it, versus wanting to get patients for a survey, versus wanting to have a deeper understanding about what's happening at sites. And so talking with people in the field really helps us to sort of distill different levels of detail for getting those encounters. I am going to, so we have talked about subject matter experts in the field, and now we're going to talk about new users for rapid evaluation. I'm going to pass the baton.
Hello. Okay. Thank you for handing that over to me. For the next stage of this presentation, I'll go over how we identify new users in real time for whole health and the CRH surveys. And to give you more concrete feelings of this whole process, I will show you some technical details to help you understand. Okay. So here I show you the workflow of identifying new CRH users using the VA EHR database. As Jamie have shared with you before, in every quarter, we add our domain knowledge and the site customization to the EHR database and the CDW work. And we use these quarterly pool queries to generate some lookup tables that gives up the clinic names, stop codes, and no-show note title exclusions that will be used later. And you probably have also seen some of the codes before. And with those lookup tables, each week we will also run polling queries to identify the new CRH users in real time. So for these new CRH users, they are qualified by having at least one CRH use in the past week, and also not having CRH use in the past 6 months, and also not meeting any of the exclusion criteria. After this weekly pool, we also have data cleaning queries, and so every week we will generate a list of patients to whom we'll send surveys. I will go over these components one by one in more detail. So this part would be the quarterly pooling that uses site information and EHR data to generate lookup tables. So we need these lookup tables because given the CIH modality, we want to get the relevant clinics and CPT codes because these are anchors for mining the new CIH users in real time. Because consider that we have an EHR database with so many encounters. So how do we know if an encounter is indeed, and for example, in-person acupuncture visits? So the information that's generated in those lookup tables are what we look for in those EHR database and as a reference to look for the CIH visits of interest. But so how do we search for these clinics and CPT codes in the EHR database? As Jamie and Ryan have talked before, we'll be use some fuzzy string match of the clinic names. We'll be using National Chart for HealthFactors, stop code, and STA3N, all sorts of useful information to help us find these location names and CPT codes. And so some practical data mining tips is that these lookup tables are regenerated on quarterly basis. So this helps us to strike a balance between the consistency and the recency of data. So this is a summary of the lookup table contents by each CIH modality. So in the first row, for example, for acupuncture visits, we will use clinic name, national chart floor, and the CPT codes to identify both in-person and the tele encounters in the EHR database. So for any given encounter in that EHR database, as long as this visit satisfy any one of the clinic name, national chart floor, and CPT, then this encounter will be counted as an acupuncture visits. Whether it is in person or tele encounter will be depend on its stop code. And so this table gives you a feeling of what are the information we are using to identify each CIH modality, and also note that it really varies with the CIH modalities. And besides the in-person and televisits, we also generate lookup tables for consult referrals. So consults are a little bit tricky in the EHR. They are definitely not among the more traditional ways of storing data in a database. So the consult visits here in VA are identified by a different methods than in-person or televisits. Because these visits cannot be identified by location names, national chart for CPT or HealthFactors. So instead, we use a very VA-specific thing as identifiers for the consult referrals, and it is called request service ID in the database. So we first use a stop code filter, and then we use the two request service names to distinguish between different CIH modalities. Basically, this will be the fuzzy string search that helps us to, for example, distinguish between acupuncture, chiro, or massage consults. And also note that we exclude the canceled or discontinued consult referral activities using fuzzy string search. So now we have already covered the quarterly pool queries that generates the lookup tables. And now we're going to use the lookup tables and deeper in the EHR database in CDW VIReC to do our weekly sampling queries. These weekly sampling queries will generate a list of new CIH users to whom we'll send the service to. So again, we're going to use the lookup tables to find the related encounters. And we really want this weekly sample to happen in sort of real time, because when we are sending down the service, we want the memories about that CIH visit is still fresh in the patients. So this sampling is on a weekly basis, as you can see from the figure in the bottom. So from the previous Sunday to the most recent Saturday, so this 1 week period is a period in which we'll sample the CIH use. So any CIH encounter happens in that period will be of our interest. And in the next Tuesday, which will be 2 or 3 days later, we will run our survey queries. And on Wednesday, we'll do data cleaning, and on Thursday, we will export the patients to whom we'll send out the surveys. So as you can see, the entire workflow happens in a week from the source data to actually sending down the surveys. So how do we implement that in practice? So first, a little bit more of the context here. To be qualified as a new CIH users, the patient must satisfy all of the following conditions. So first, the patient must have at least one CIH visit in the past week, basically the 1 week sampling period. It can be in-person, tele, or consult of any CIH modalities, but the patient must have no CIH visits in the past months, at least in the VA database. And also the patient must not satisfy any of the exclusion criteria. So that means our weekly sampling queries will first identify all of the CIH visits happened in the past week. And the second, identify all the CIH visits in the past 6 months, excluding the last week, so that it can identify the new CIH users. And third, it will run a few exclusion criteria. For example, the patient has to be between 18 and 89, must have a PCP team, and also should have chronic pain. So all of these queries will be run in Microsoft SQL Server, and the runtime is around 30 minutes. So again, this table is a summary for the query codes to identify each type of encounters using the information we generate in the lookup tables. So for example, for identifying acupuncture visits in the EHR, it can be located either by location names or by CPT code. So this, to give you a more concrete feelings about the technical implementation of the entire workflow, I will show you some example queries. I hope it's not too overwhelming, so I will do some annotations in the process to help you follow through. Okay. All right, so I hope you guys can see the laser pointers. So this specific query helps you to automatically update the query start and date stamp of each week. So because the query will be run every week and with as minimal of manual input as possible, so this code snippet actually updates these important date stamps. So we have week start, and the week start 7, which is 1 week after week start, and the week of 6 months prior, which is the date that's 6 months before. We'll use that to find the new CIH users. And then the input of this code snippet will just be today's date or the date of the survey sampling query runtime. And this code will automatically update these date stamps. And for this snippet, it's a bit long, but really it's just to identify the acupuncture visits by CPT codes. So as you can see here, we use the acupuncture location list that's generated in this quarter to identify the visits. And we also require that the visits happen in the 18 VA flagship sites. We also apply some stop code exclusions. And using a similar logic, we also find acupuncture visits by location names. So again, so this acupuncture location list is the actual anchor of us to find acupuncture visits in the EHR every week. And then we are combining the acupuncture visits by both location and CPT codes, which is here, to find all acupuncture visits happened in the last 6 months. And we also exclude the no-show visits by the no-show titles. So this no-show title lookup table is also generated every quarter. And the last step is to find the new CIH users, which is basically first locating all of the patients that had any CIH use in the past week and exclude those who has any CIH encounter in the past 6 months. And then this code will generate us a list of patients that are actually new CIH users in the past week. So this is the technical implementation part of this workflow. Thank you everyone for your attention, and now we're accepting questions.
Thanks, Xiaoyi. So we actually do have a couple questions. We may need some clarification from Kathy on this one, but I'll read it just in case you guys might know what she's referring to. And I think this question might be for Ryan. Her question is this an IRB approved platform? And is this a health treatment methodology under VHA? And is this research? Do we need some clarification on that, or?
Well, I can start by clarifying that this was all operations research. So no IRB. This was quality improvement for our, the Office of Patient-Centered Care. Maybe there might be some portions of that question that need clarifying though.
Yeah, Ryan, this is Steve Elliott. So there are both IRB approved studies. The approach trial does do the same work or similar work, but a lot of the work presented was QI work. So, but it's all the data are in CDW, so you can get IRB approval to do it if it's an IRB study.
Yeah, that's a good point. Thanks, Steve. The real-time part that Xiaoyi was presenting, that's for a research trial. The sort of general operational reports that I was describing earlier, that's all quality improvement work.
Okay, so Kathy, if you want further clarification on that, just go ahead and put it in the Q&A and I'll pass that along. She also wanted to know where's the data on measurables and who are the targeted patients?
Okay, that sounds like the question could use clarification on what does she mean by measurables?
Kathy, we'll let you, if you could explain further in the Q&A, we'll pass that along. So from your perspective, how has the data changed over time, specifically for how these visits are recorded?
Jamie, I think you might have the most to say, having talked with the folks on the ground and seen how that changes over time.
Yeah, absolutely. We've definitely noticed a convergence of having more CPT coded visits and more visits that have overlap in coding. So when this project began, sometimes we would be pulling with a clinic location and nothing else, a CPT code and nothing else, or two factors. As time has gone on, we've definitely noticed that we're getting more. We're getting, a CPT and a CHAR4 and a clinic name. People are setting up their clinics to better reflect the services that are being offered. And so that's definitely a trend that we love to see, because these encounters are getting easier to find and code.
Yeah, maybe one thing to talk about too is the push to tele. COVID-19 and the pandemic shifted a lot of things to tele, and there was a lot of, I think, maybe confusion about how to code some of these things initially at the beginning. And there's a lot of clarification on that, and I think it's still very much a work in progress. And how to kind of code tele Tai Chi classes that are delivered through BBC and capture that use is really an interesting. Tele yoga is definitely an interesting. Tele is, different, interesting, ongoing change.
Yeah, and I think we're anticipating with the primary care and mental health integration, like if sort of everything becomes whole health, then what is whole health? So that will definitely change the coding of whole health in a large way, probably in the upcoming years.
Do you expect that there will be, do you have any anticipation of how Cerner transition might affect this data as well?
That's a great question. I mean, the Office of Patient-Centered Care and Cultural Transformation has been working really closely with Cerner to kind of work on coding of some of these non-traditional activities, things that are CPT codes, especially since Cerner was a billing platform, like that makes a lot of sense. And one of the hopes is that working with the AMA to get some of these other modalities defined better as actual CPT codes will help with that. But you know, the transition for HealthFactors in general and for billing activities through Cerner is a huge work in progress. And I think the MCAO office, the accounting office, is trying to translate some of the char4 coding. So we're eagerly looking to see how to follow some of those things. The Spokane site has not been a huge whole health site, so they're not really a great test case yet. But I think as some of these other sites expand, we'll learn a lot. So.
Okay, thank you. And Kathy provided clarification on her question about measurables. She's speaking specific to the treatment of these holistic modalities. How are the patients responding and how is that measured? Thank you.
I'm reading the question, Kathy. So the question is like, how can we outreach to VAs who are not as engaged in?
Oh, sorry, she has one above that. That's her next question. So the original question is, where is the data on measurables and who is the targeted patients? And she clarified that she's speaking specific to the treatment of these holistic modalities. How are the patients responding and how is that measured?
I think you might be referring to some of the, different changes in patient-reported outcomes and well-being measures, pain measures, Promise 10 measures, engagement and care measures. So there are a couple of very large surveys that Office of Patient-Centered Care and Cultural Transformation are doing that are QI surveys. One that Xiaoyi was talking about the sampling for is one of them. So, so those are patients, who are newly using some of these CIH modalities, and that office is definitely looking to see how health outcomes are changing over time for those patients who do use those modalities. So, so I guess the target patients are the patients who are, engaging in these care processes, and where is the data on the measurables? So those are survey data that are being collected, and I guess watch this space. There are data coming out about the value of that. So. But that's part of the survey work and not necessarily the EHR data.
So you can actually jump into her next question then if you'd like. Many women veterans, as she understands, really do appreciate these holistic modalities and many are not aware they exist. How can we outreach to the VAs who are not as engaged in holistic treatment?
That's a great question. So I mean, the Office of Patient-Centered Care and Cultural Transformation is really working to help sites build their programs and market them, make them available to veterans, kind of increase the referral pathways. So I think some of the links earlier on to a lot of the resources for those sites who are starting to get engaged in whole health and build their whole health programs are sort of a place for that. One of the things that's really interesting with the push to VVC is that some of the places can now offer lots of virtual classes, and they don't necessarily have to be at a VA that has that class available. So I think there's some work across the VISNs to build some of those centers that are offering more classes. There's some trade-offs with that, making sure that there's somebody who can watch the veterans participating in some of the tele-Tai Chi and other modalities, so they can't get too big. But so it's definitely interesting. I mean, I think the tele work is expanding, and that is one way. But there is, I think, as Ryan talked about at the beginning, sort of sites are now really trying to engage primary care and mental health in whole health care. And that is sort of the next round for the next couple of years. And that will be another national initiative. And so I think most VA sites are going to be building and expanding their whole health programs and their CIH offerings.
Kathy said, thank you. It's all very helpful information.
Awesome.
We do have one more question. Just a reminder to everyone else on the call, if you want to ask the presenters a question, you can put it in the Q&A function. So this question is there a good place to go or a video to watch to learn SQL querying in CDW?
That's a very good question. VIReC has great resources. I know that's where I started. They have, in fact, I think some of the, at the very beginning of the slide set today, there were some of the upcoming presentations are sort of, introductory CDW presentations. There's also the Vinci Academy. They have fantastic coding resources, including stuff on SQL. So those are sort of your NVA resources for that type of, SQL learning resources.
Yes, thank you for that plug, Ryan. We appreciate that. We are going to be kicking off our series starting next month for the fiscal year, I should say. Starting, and I'll make this announcement soon, but it's starting with our Meet VIReC, the Researcher's Guide to VA Data Use. We also have an overview of VA data and a cyber seminar on access. So if anyone has questions on how to get started, those cyber seminars are great resources. To the presenters, do you have anything else that you want to jump into or clarify before we wrap up?
Yeah, trying to deal with non-traditional encounters is probably not the best place to start with SQL coding in CDW. It's really, really, really messy. So, but it's kind of fascinating what you can find if you dig deep enough in CDW.
All right, well, Ryan, Jamie, Xiaoyi, and Steve, thank you so much for presenting today's session. To the audience, if your questions were not addressed during the presentation, you can contact the presenters directly. You can also email the VIReC help desk at virec@va.gov. Okay. There is the presenter's contact information right there. And as I said, please tune in for the next session in VIReC's Database and Methods CyberNet Seminar Series on Monday, October 4th at 1 p.m. Eastern. Maria Soden will be here to present Meet VIReC, the Researcher's Guide to VA Data Use. We hope to see you there. Thank you once again for attending. We'll be posting the evaluation shortly. Please take a minute to answer those questions. Let us know if there's any data topics you're interested in, and we will do our best to include those in future sessions. Thank you to the presenters once again, and everyone have a wonderful day.